I'm really hoping very hard this session works very, very well. So our plan is to show you 4 slides of patients that have had side effects from their targeted therapies. So our expert panel, you've met Alex. Next to Alex is Beth Ebi-Sandy, and Beth is one of our very valued members on the TONF team and works in the States and has great expertise in managing targeted therapies with lung cancer. Next to Beth, we're going to slip over to Scotland and meet John McPhellum, who's a lead lung cancer nurse in Scotland. And then we're going to sort of come down in the world, geographically only, to Western Australia to meet Caitlin Broderick, who's a lung cancer nurse there. So we're going to have an international perspective on managing toxicities for our patients. So as always, it really is about our patients, and as nurses and physicians and those involved in our patient care, we want the best possible outcome and to keep our patients on treatment. So that's going to sort of set our scene. So each of the panellists is going to answer what would happen in their region, okay? And then what I would like you to do, the audience, because we need your participation as well, I want you to ask us questions. I want you to challenge us. And if you would do something differently for that, what you're seeing on the screen, then please let us know, okay? So I hope, fingers crossed. Okay, that's us. So this is our first friend who's got stage 4 non-small cell lung cancer. Very surprisingly, back in the day, 5 years ago, he asked to be tested. We didn't routinely test these patients. And you can see his rash. It's very uncomfortable, skin's dry. He's a typical Aussie bloke who really would never put cream anywhere near himself, let alone sunscreen. Okay, so what are we going to do for this guy in Asia? Do you want me to get back to seeing our friend?
No, that's fine.
Okay. Alex.
Well, you kind of heard my stand earlier on. I think for this patient, we probably will end up giving some kind of systemic antibiotic to reduce the inflammation. So, and potentially a topical steroid. The problem is, of course, the extensiveness of the rash. So the amount of steroid that you need to put on will be quite a bit. And I don't know whether or not the patient really want to do that. But an antibiotic will be something that we'll consider. Depending on which TKI we're talking about, I don't have enough background, but
Erlotinib.
Oh, is it erlotinib? Okay. So this is a tricky one. This probably will not have dose reduced in the very upfront,
No,
but it's, yeah, probably not. But if it's a afatinib or so, there might be some consideration.
Yeah. Can I get you to think also about the rash, that with that rash, he had no rash where he's heavily tattooed.
Correct.
Yeah.
And that is interesting.
Yeah.
Yes, and I apologize. I have laryngitis, so but the tea did not help.
I'm sorry.
Tried. So I said I think this is either grade 2 or grade 3, and I said based on what the patient says, because is he in pain or not?
Yeah.
I've had
really
patients.
distressed.
Yeah, because I've had patients come in with a rash like that, and they're like, yeah, nothing's wrong. I'm fine. And I'm thinking, oh my gosh, you look terrible. So sometimes I may say, oh, okay, well, I'll give you something topical and we'll move on. Or if he's in a lot of pain and distress, then I would say it's probably a grade 3, and depending again what drug he's on. I would say for erlotinib, make sure he's taking it on an empty stomach. Yeah. If he's taking it with food, it can speed up the absorption, and then it's just going to give you more side effects. It's not going to make the drug work better. It's just going to give you more side effects. So I put dose reduced question mark based on which one he's on. Like Alex said, there's actually some data if he was on afatinib that 30 milligrams is almost pretty much just as good as 40 milligrams. So if he was on afatinib, I would for sure go down to 30 probably, because there's really not much difference in efficacy of the dose, which may be a little controversial, but there's definitely data to support that. I would definitely probably try to give him something topical. I wish I worked with Alex, because I would be that person that prescribes. I'm a nurse practitioner. I prescribe like a tube this big Because I'm not paying attention. I don't know what is 5 grams versus 50 grams. I don't know. So the poor guy would come home from the pharmacy with a tube this big to rub all over him. So that would be terrible. So yeah, you'd have to pay attention to order some big amounts if I was going to give him topicals, because he'd have to put it all over his trunk of his body. So yeah.
Okay, so Scotland.
If you think you can't understand me, wait till you hear this Scottish accent.
But John will slow down, I think.
I'll do my best to speak slowly. I don't think I would manage it any different to Alex and Beth. I think that probably it would depend on if this was a first episode of an eruption. If it was a second or third episode, I think we would probably manage it differently. I think we would certainly, if there was pustular eruptions, we would, in the UK, based on our expert consensus guidelines in the UK, we would use an antibiotic, an oral antibiotic. And other things that we would do would be to swab any particularly affected areas, and we always photograph the area for future comparison, future reference, so that if a patient comes back in a week, you can have a good idea of whether or not your intervention has been successful. And I think as well, we would, if it was a second or third eruption, we would think about a dose reduction and possibly a treatment interruption. And certainly we would consider systemic antibiotics and possibly systemic steroids also.
Thanks, John. And all the way down under.
And New Zealand, Anne.
And New Zealand.
So rather than repeat what we've discussed, Australia wouldn't do anything that different, other than the fact we have a very powerful sun and it's often very hot. And although we've talked about sunburn cream, we also have slip, slop, slap, going back to the 1970s. And that's protective wear for the sun. Always wear a hat, light, loose clothing, and sunburn cream. But also, I guess, to think about the other aspects of how it impacts the patient. So we've talked about managing the rash itself, but what's expensive, all these creams we're asking patients to buy, because for a lot of people, they actually won't buy the creams when we say you need to keep your skin moisturised, unless we give them a pack, which we used to do. We no longer have those packs, so patients are left to buy their own creams, and I'm pretty sure that some of them don't do it until they get the rash. And in addition to that, the whole, are they able to reach their back to put cream on their back? It's for elderly people or people that live alone, the practicalities of some of these things are slightly unrealistic. And also the choice of antibiotics, I guess living in Australia, we're probably more inclined to choose the minocycline rather than the doxycycline. But I guess also the psychological impact of the rash. We shouldn't underestimate the way that affects patients, their ability to go to work, their interactions with others.
Yeah. Thank you. A radiotherapy nurse once gave me a very good tip, and her thing was that she'd get everybody's got a wooden spoon at home, and that for difficult areas, that to use a wooden spoon to put the cream on for a rash. So I think that's what she... Does anyone else photograph and put it in a file?
So we use photo technology for other reasons, and to monitor the rash, so that patients can send us their rash and we can see whether it's improving or not. Also, people tend to underestimate their rash, and they say, I've got a little bit of a rash, and they send you through this photo and you're thinking, I think you need to come in. And also our relationship with GPs and primary care needs to be really good. They need to know the patient's on the rash, rather than the patient turn up to their GP and have a rash and they didn't even know they had lung cancer, let alone on erlotinib or whatever it might be. So we need to be really closely in contact with primary care.
Good point. Thanks, Caitlin. Okay, next problem. So we've got paronychia. So it looks pretty nasty. Those toes they're clean, but nobody would want to own them. So, Alex, what are you going to do for the paronychia?
We worry that might be infective, and of course with a little bit of bleeding on the side. So we probably will give some antibiotic ointment. So we have some triple antibiotic ointment that's available. So we probably would just use that. We do routinely warn our patients about wearing open-toe shoes in that situation. So again, that's a common practice in among many of our Singaporean patients. So we ask them to wear like closed toes for a while or so just to protect themselves. But the question is whether or not that needs some surgical, so to speak, interventions at this moment. I probably won't do anything. I probably will just start with that for now, just to see how things will go.
Thank you.
Yeah, so it's interesting. I would probably tell that patient to wear open-toed shoes as long as it was in a clean environment. Just, to let it, I don't know, breathe or get the air to it. But I would be concerned that there would be more friction with closed-toed shoes. So I think that would somewhat depend. I said it was a grade 3 because it looked really like it was interfering with ADLs to me, but I don't know, depending on the patient. I wrote cauterize with silver nitrate sticks in case that was bleeding. That sounds awfully painful, though, and I'm not overly comfortable doing that in my clinic setting. I would probably send that patient to a foot doctor. Because that might be, that one in particular with the bleeding, flesh, I don't know. Certainly I would have that patient on some kind of antibiotic, maybe even oral. But I think oral antibiotics don't penetrate to the nail beds well, is what I'm told. So, that can be difficult. I'd send that one to a foot doctor.
Yeah.
Thank you. I think we would probably treat this patient with a topical antibiotic and an oral antibiotic and assess after a week. In Scotland, the majority of the time it's a bit colder and wetter, so open-toe shoes outside aren't really an option for our patients. But certainly patients at home, we would probably advise them to try and keep their toes uncovered if they possibly can. But again, I think we would probably be asking a foot specialist, a chiropodist, to see these toes. I would think so.
Thank you, John. Caitlin.
So this was actually one of my patients, and as it turns out, she was 43-year-old and she worked in customs at the airport, and she actually had to wear as an outfit. She had no option, and it had steel cap shoes, those thick, heavy shoes. But in actual fact, she was able to wear them. She changed her footwear when she wasn't at work and did wear open-toe shoes. But in Australia, obviously it's hot and you need to be exposing that foot, otherwise it's going to sweat. But in the workplace, it was okay. And she also felt that it protected her foot because she was really worried about people standing on it. But we did send her to a podiatrist, and she did get actually a special pair of open-toe shoes that gave her not splinting but protection. It wasn't just an open-toe shoe. So that was useful. And I guess the other thing is pain. She didn't have pain, but I'd always check that in assessment and check their fingernails as well. And obviously would refer to an OT if they were interfering with ADLs.
Anybody? Yeah?
Sorry, why haven't vinegar in Scotland?
It's in the UK consensus guidelines that it might be something that would be helpful and soothing to patients, and there were a couple of dermatologists on that expert consensus group. So there's no great evidence base for it, but it's thought that it might be helpful and soothing, because I don't think you can underestimate how painful that looks, and if something that's going to soothe it might be worth trying.
This poor lady with her trichomegaly. Yeah, it's a good one, isn't it? So, Alex.
Yes, so this is one that we have a lot of difficulty because we don't have anyone who can specialize doing this. We refer a lot of them to our nurses and to see whether or not some trimming can be done, because a lot of patients are very uncomfortable actually trimming them on their own. So they ask whether or not in Asia there are a lot of these beauty parlors, right? Whether or not that they can go to beauty parlors and get them done. We actually advise against it. So recently what we have been doing is we refer our patients to ophthalmology and let them take care of it. But a lot of patients get very scared when they start seeing another crew of doctors. But it's something that we just have to implement in our patients.
Yeah. This was my patient, and I wanted to show you she had just trimmed them. When I took the picture, she came in, I said, oh, wow, your eyelashes are really growing. She said, yeah, I just trimmed them. I said, oh my gosh. So Yeah, so she had just trimmed them. She did not do it herself. So that's in our mask recommendations. We actually recommended not to trim. But I think in the real world, she had her caregiver trim them carefully with like not regular scissors, but actual like, nail scissors or, like the baby scissors that you would trim baby, nails with. So we recommended in our mask guidelines not to, but I think in the real world, people will have to trim them a little bit because they will be out of control. And remember, they're also very brittle and wiry and hard. They're not soft at all. So it's very easy for scratched corneas and irritation of the eye. So I'm very quick to refer to ophthalmology. And she doesn't have this, but most people also are going to have crusting and some degree of conjunctivitis in their eye. So we'll often prescribe them the erythromycin ophthalmic ointments as well to help with the crusting. She didn't, but a lot of patients will when they get those long eyelashes.
Thank you.
Thanks, Beth. I think our management would be very similar to what Beth has described, but if there was any sign of conjunctivitis or infection, we would probably ask an ophthalmologist to see this patient probably same day, if we could ask them to see them same day. And I think, trimming is useful, but again, like Alex, it would need to be, we get the patient to have them trimmed by our ophthalmology nurses in the department, and I absolutely would advise patients against going to a beauty parlour or somewhere to have them trimmed, because that, I think, could be very detrimental.
Okay. Thanks, John. Caitlin.
It's not nice being fourth in line because everyone has said everything. But I guess the only other thing to add is this is not an evidence-based, more anecdotal. People that have conjunctivitis are often very sensitive to sunlight and also to the air conditioning vents. So often I find patients with some sort of conjunctivitis, trichomegaly, I'll suggest wearing sunglasses more just to protect the eyes. But other than that, it's all same.
Yeah. So diarrhoea. What would your clinical assessment and management be for this patient?
There's no picture for that one anymore.
No,
was.
that was.
In our original version, there was.
We had. I'll tell you. It's actually very funny if you understand what it is.
It's a Bristol scale, right?
The Bristol stool chart, and I don't think it's as commonly used as it is in Australia and the UK, and so we took it out.
It's more for teaching, I suppose. So I think the one that we described was supposed to be the type 6 stool. So sort of loose, but not to the point it's all liquidy. So in any case, so I think what I've talked about earlier in my talk is that for these patients, we'll provide a prescription of antidiarrheal just to decrease the peristalsis. But again, don't forget about oral rehydration. I think that's something that we often forget in case somebody really has substantial amount of diarrhea. And to counsel the patient when to come back for urgent care, I think that's very important.
Yeah.
Oh, I also mentioned discontinue any laxatives. I think that's also something that we tend to forget as well, because a lot of our patients, when they're on pain medications, they're on laxatives, and they continue on these medications while they are on the TKIs, and then we just forget. So I think, again, medication reconciliation would be important here.
Thank you, Beth.
Okay. You're welcome, because I made them remove the picture. You're welcome. So I think the diarrhea is fairly manageable with loperamide. One exception, the afatinib. The afatinib, I have definitely dose reduced due to diarrhea. And I'm pretty quick, again, that 40 to 30 milligrams, not much difference in overall survival. So I would be pretty quick to dose reduce. And that one is like 95% of people get diarrhea. So, but usually loperamide. We also have a drug called Lamodal, which is diphenoxylate atropine, which is a stronger antidiarrheal that we can prescribe as well. I don't know how that one translated, but.
If the diarrhea resolves after about 48 hours, we would continue the patient on the dose of treatment that we're on, particularly if it was erlotinib. But I think if the diarrhea continues beyond that, it's the practice in the UK to have a stool culture taken for the patient, just to be absolutely certain there's not another cause for the continued diarrhoea. The other thing that we do is, certainly in Scotland, is that we take a fairly detailed bowel history from patients before they start these treatments, because everyone's bowel habit is quite different, and you know, there can be a massive range in what one person thinks is diarrhoea to the next person. So I think having a good baseline is important.
I think with this, it's the thorough assessment that counts, but also using the same language as been mentioned earlier. I think diarrhoea is one of those things that if you receive a phone call to say, you know, the patient says, I've got diarrhoea, their diarrhoea and what you consider diarrhoea are two completely different things. And that's why we use the Bristol stool chart in Australia. And we get them to point to which type of diarrhoea they have. And they're quite comfortable doing that. So we must breed other people. But anyway, the other thing I'd like to say is that with the appearance of the stool, just to be careful that it's not got anything else causing the diarrhoea or loose bowel movement, and just their other needs. So if they're coming into clinic, it can be really awkward if they're coming in, you don't know they've got diarrhoea and they're sitting there with a pad on. You just have to be considerate, I guess, of other aspects, not just their diarrhoea.
And it's actually about keeping patients on treatment, isn't it? Yeah, because often I find that it's diarrhoea that is what gets people off treatment. And often they under-report to stay on treatment, like with, whatever the side effects are. So I think, unless we... Oh, yes, sorry.
Even better. Yeah, one thing I've found with some patients with TKIs is actually talking, especially with suritinib, about the time of day that they actually take the medication, and that's something. You know, if there's a bit of flexibility with it, it might be that they take it if they're going to work, or if they're not going to work, or if they've got an important function, and giving them a confidence in them and their medication.
Yeah, no, that's a very good point. It's about quality of life, isn't it? So I think that we've all learnt a lot, and we've solidified a lot of what we know. And I just saw Mary cringe then at the pun. But it's also very important to be culturally aware and to not be offensive, and, you know, to not use the Bristol stool chart if you don't have to. But I think it's a good thing to use. So thank you to everyone. I think this has been a very good and successful session, and we really appreciate everyone's expertise, and thank you.